Hello, everyone. My name is Andrew Herring. I'm very happy to be here. I was kind of excited to hear this last talk because I feel that the ERs fits really well, potentially, in this understanding of things. So I'm an emergency physician, and I'm also addiction boarded, so I see people in an ambulatory setting for addiction, and I'm specializing in pain as well, so I have a pain practice as well, all at Highland Hospital. Most recently, we're setting up something called the ED Bridge, which is a statewide project to link emergency department care to the hub and spoke expansion project. So basically, how can the ERs, using this terminology of touch point, be the touch point? What can we do with that? I can just tell you today, before I got here, so before lunch, we started 3 patients on buprenorphine just this morning. It's really busy, right? So this morning it was 2 patients from an encampment in Berkeley, and then 1 guy who came in from Arizona and had a gap in his buprenorphine care. So the dislocation is a huge, or marginal housing, or however you call it, mobility is just a defining characteristic for a huge number of our patients, and our system is not set up for people who are moving between place and place. It's just terrible with the Medi-Cal and all that. So the ER is really the only place, realistically, that people between care can go in a lot of communities. So I just have to show this really quickly. Randomized controlled trial comparing buprenorphine and diamorphine for chest pain and suspected myocardial infarction. Does everyone understand what that trial is? So that's intravenous buprenorphine versus heroin for suspected heart attack, right? And this is from the 70s, and the only reason I put that up is just to drive home the point that how we use medications is evolving, right? So buprenorphine is a broad medication that can be used in a lot of different ways, in a lot of different modalities, sublingual, injectable, long-acting, etc. And there's a big room for evolving and modifying how we use these things depending on where, when, and how. So this is the big trial that put emergency department initiation of buprenorphine on the map, done by Gail D'Onofrio and David Feline and their team at Yale. And they had basically an excellent outcome. It was 80% of the folks who were started in the ER then followed up at 30 days. The only other data that there's out there on the ER is a trial done by Berg over at Johns Hopkins, where they're just treating buprenorphine, using buprenorphine to treat withdrawal. This was mainly intravenous. Their main outcome was looking, did people come back, bounce back? Did it work for treating withdrawal, and did people bounce back? They didn't. There was no increased return visit to the ER, this idea of creating an overwhelm, the buprenorphine horde sort of coming and taking over your ER if you start using it. That didn't happen. So basically, our challenge here in California is we know this idea works. We know buprenorphine works, but the Yale model is expensive. It requires a lot of resources. It's not practical to scale up to an entire state. So what we're trying to do is figure out how do we actually employ this gigantic emergency medical system, which is built out, it's there, it's 24/7. Where does it fit as a broad public health response to the opioid crisis? Some of the barriers we're seeing amongst ERs are, ER docs are not all going to get waivered, right? Not going to happen. It's not a realistic thing. Either the waiver goes away or we think of something else. The other one is fear of diversion. Part of the problem with continuation of any opioid is that rightfully there's more scrutiny of how opioids are prescribed, but it also means that people are really scared to prescribe opioids, including buprenorphine. So telling a doc who doesn't do this all the time, hey, you have someone with opioid use disorder or addiction who you don't know at all, and I want you to put a script and send them out into the community is a hard sell. A lot of people really just aren't comfortable doing that. And then finally, we don't have time for complex handoffs. So deep psychosocial interventions and linkages and all that kind of stuff is not going to happen practically in the ER setting. So what we're trying to do basically is we're distilling this down. And all we want to do is basically get every ER in the state to treat withdrawal with buprenorphine. That's it. Get bup in the Pyxis and to use a real dose, not 2 milligrams, not 4 milligrams, but a dose that's going to last 24 hours. And then we want to go to the hubs and basically say, you got to take these people in without warm handoffs, without fancy referrals, without all these hoops. You got to take them in and treat them. And that is basically the core of our plan. So the adjunct is we're working with the California Poison Control so that if there's an ER doc who doesn't know anything about addiction, he doesn't know any of the data we just learned. All he knows is that he can diagnose opioid withdrawal. He can call the poison control, and they can tell him, okay, yes, this is how you confirm it's opioid withdrawal. These are the contraindications. These are indications. This is a suggested dose. And he or she can give a substantial dose that can then be a pharmacologic bridge to the hub and spoke system, and they can pick them up. And that's where we can pull in all the work that the people in this room do around how do you really engage and turn that 72-hour, that 48-hour initiation into a long-term win. So part of the things that we're doing is we're tinkering with the doses. So we know that basically the peak of these doses occur around 60 to 90 minutes. We know that there's this ceiling effect with buprenorphine that makes it safe in terms of respiratory rate, in terms of sedation, right, all the way up here towards 32 milligrams. And we also know that when if you just treat withdrawal as a symptom, you just kind of throw out all these terms. Is it detoxification? Is it induction? Is it initiation? Just treat it like it's pain or nausea or whatever, right? That this is basically comparing 8 milligrams to 24 milligrams, and the larger doses do a much better job of treating withdrawal. And then you have the added benefit that then once you get to the ceiling dose, the pharmacokinetics are such that you get prolonged, sustained suppression of withdrawal and craving, which you then can use as this bridge. So that's kind of our plan. Very briefly, at Highland, we've been doing this for about a year. Right now, we're seeing about a patient a day on average. Some days are busier than others, like today we just had 3 in the morning. So this idea of opening the doors, it works. All of this happens in our fast track area, which is our very low acuity area. It happens in a plastic chair. There's not extensive monitoring. It's not a fancy system. And with that, I'll turn it over, and we can chat at part of the discussion. Thank you.
We're gonna do questions after each of the speakers finishes. So our next speakers are Dr. Jamie Carter, who is one of our fabulous addiction medicine fellows, and Dr. Barry Zevin, who runs the street medicine and shelter health program for the health department and is a mentor of so many of us.
We're not going to talk at the same time, so I think we'll be okay. All right. I just want to quickly describe what we do, and then I'm going to have Dr. Carter describe a little bit about what we found in the first year of doing it. So street medicine and shelter health. More or less, we are working with high-risk, high-vulnerability homeless people who the rest of the healthcare system is not, they're not getting what they need from the rest of the healthcare system. And we are a comprehensive transitional primary care model. We're really trying to do everything for everyone. In that high-risk population are many people who are homeless, who are opioid users. And we recognize that we need to be able to offer something to them because they were people who are not getting care, even though our system is pretty robust as far as the availability of care. We talk about low-barrier buprenorphine access. What are the barriers? There's barriers on the patient level, barriers related to no insurance, no ID, no phone, unable to make it to appointments, chaos in their lives in every area, and chaotic drug use as well. What many medical providers would consider high risk of diversion. people who have their stuff stolen all the time, or who have very high incentives to try to get maximize benefits from whatever they've got. But there are also prescriber-level benefit barriers. You've, of course, heard lots about judgment and stigma today, but in general, the way we work in the medical system is we say, we'd love to help you, make an appointment. If you just show up whenever, that's really disruptive. And yeah, it's a barrier for if we're saying, you know, the people who need us are likely to only have one day of the month when this is the day that they're ready to do something. And then there's systems-related barriers, not enough prescribers, and certainly not enough same-day access when people are ready. What do? We engage people with outreach workers, often peers. We offer drop-in visits in our clinical site, in an open access site. We try and provide this service wherever the population that needs it is. That's at syringe access sites, that's at navigation centers and shelters, that's streets and parks. And we've had different, lots of interest from patients in all of these areas, different kinds of follow-up in the different areas. When we find somebody who might be interested, we do assessments, and that assessment looks like an assessment for buprenorphine would look in any medical setting. We really try to do a complete assessment. And then we do same-day prescription of buprenorphine for a non-facility-based induction. Here's the prescription, here's the way to get it, and here's the education about how to start. You start it where you want to, when you're ready. And a lot of this has to do with a close collaboration we have with the behavioral health pharmacy that's part of the Department of Public Health. And we're able to dispense, prescribe and dispense to patients who have no ID and whose insurance situation is not clear. So I think that stuff I already talked about. Our primary goal is retention in care. That's just thinking the way we think about any substance use disorder treatment. Retention in care is the goal. That means, are they still seeing us? We've got secondary goals: abstinence, reduction in harmful use, overall improved health, and we're looking at that stuff. But if we're still connected to that person, that's the primary goal. And this is a population that does not connect or stay connected. We know most of these folks have been out of care, maybe use emergency departments, sporadically use systems. Having them stay connected with us is I aimed for success if 20% stayed connected. You'll hear what our results were. Okay, some results from the pilot.
Okay, so we saw about 95 patients in the first year. Since then, we've seen 250 total since we started, so a lot of interest. Our patients are really medically and psychiatrically complex. They have really high rates of comorbid substance use, in particular methamphetamine use. About a third of patients were seen at the syringe access or syringe service program, 10% on the street, and the rest in the clinic. And about 70% of patients came back after the initial visit. So this figure shows our retention in care and the retention on buprenorphine by month over the year. Retention in care is in blue, and I'll note these are people that like everyone that we even saw one time is included in this analysis. So 62% of patients were retained in care at a month, dropping to 41% at 6 months and 22% at 12 months. And then the purple line shows retention on buprenorphine. And I'll just note that that's people that are taking buprenorphine relatively continuously over that period of time. There's even more people that aren't reflected in this figure that were taking it intermittently, a week here and then maybe not coming back for 2 weeks and then coming back and getting another prescription. So about 37% on bup at a month, and then that kind of stabilized out at about a quarter, staying on buprenorphine over the entire year. And you'll note that everyone that was retained in care at a year was also on buprenorphine. So, we looked for evidence of decreased opioid use because that's often something that's, in addition to retention and care, is used to sort of evaluate success in an addiction treatment program. And the reality is that the majority of our patients are continuing to use heroin and meth. 64% of the urine toxicology tests in the program are positive for opioids, and 72% are positive for methamphetamines. But some patients are decreasing their opioid use, and we have kind of objective evidence of that. So 36% of the urine toxicology tests are opioid negative. About a third of patients who came back after the initial visit had at least one opioid negative test, and 14% were abstinent from opioids on all of their tests. But when we talked to patients, we heard really overwhelmingly kind of these narratives of people saying that they were still using some heroin, but they've substantially decreased their heroin use in really meaningful ways. And I don't think that's really reflected from just looking at urine toxicology data. So we also did some in-depth interviews with patients to get a better sense of kind of what their experience of being in the program was. And so I'll just share one of these quotes from patients that sort of highlight kind of the decrease in opioid use. So one patient says, "And the blocker," which is how she refers to buprenorphine, "it helps me. Don't get me wrong, I still have my street addiction, but this is nothing. I was on like $100 worth of drug, now I'm down to 10. So I know it's working because I've come down a lot." We also asked patients about kind of what the health effects of being in the program had been. One patient said, "My health, now that's something I'm still working on. I'm going to start my Hep C treatment, I think today, the process, and I'm on anxiety pills now, and that helps me a lot." So someone who was able to engage in primary care and mental health care, engage in Hep C treatment because of being stabilized on buprenorphine. Other people reflected on how they had more money to kind of address their basic needs. And then one of my favorite quotes was a patient who said, "Well, I'm alive, I haven't overdosed, so I'm pretty good actually." And I think that just gets at kind of the key goal is to keep people alive. So, we face some challenges with the program. The demand outweighs the capacity of our team, which I think is both a challenge and something that's really promising. There's really overwhelming interest in this kind of care from this population. There are barriers to transitioning patients to more conventional substance use disorder treatment programs when we feel like that's what they need or what they want. There have been instances of diversion, obviously, that we've had to address, and we desperately need treatment for methamphetamine use disorder that's destabilizing this population to a large degree, and our patients' basic needs remain unmet. So in conclusion, we think that this pilot successfully engaged and retained a subset of really vulnerable patients in care. And about a quarter of those patients were able to maintain on buprenorphine relatively continuously over a year. With intermittent buprenorphine use in even more of those patients, we feel like that's really promising. Just considering that a lot of these patients are people that would have been kind of considered by more conventional buprenorphine programs to be too unstable for the program. They might have been told to go to a higher level of care, which often just means that they're not going to get any care at all. And so by kind of sort of reevaluating and broadening what our view is of success in a buprenorphine treatment program, we're able to help people decrease their heroin use, kind of better engage in medical care, and have improvements in their health. And so while kind of achieving continuous treatment with buprenorphine and getting to the point of opioid abstinence are goals, we think that intermittent treatment with buprenorphine and the decreased opioid use that were more common in this program in particular also likely confer significant reductions in opioid and injection-related harms and benefits for the patients who are participating. So I just want to acknowledge the rest of the street medicine team who does this work, Barbara Garcia in the Department of Public Health for supporting this program, and the 6th Street Harm Reduction Center, Terry Morris, the director, who's been great to work with, and all the volunteers that do the work there every day. Thanks.
Thank you. Our next two speakers are both from the San Francisco AIDS Foundation. Pauli Gray, who's a hepatitis C coordinator and harm reduction specialist, and has been doing this for 19 years, and Pierre Crouch, the director of nursing, and Dr. Crouch got his nurse practitioner and PhD from UCSF, and has led a large nurse-led PrEP health program as well.
All set up with a clicker. So again, my name is Pierre. I'm the director of nursing at Magnet. We're a nurse-led sexual health clinic, the largest sexual health clinic in San Francisco, and we have one of the world's largest PrEP clinics. And Pauli Gray is our, do you want to say hi? Do you want to say hi? Say hi.
Hi, I'm Pauli. We're both Batman in the Hep C and opioid situation. Got a lot of friends here. Hi, y'all.
So about a year ago, I had this idea to incorporate Hep C into our sexual health clinic over at Magnet, and that led me to meeting up with Pauli, who I found out he actually had been wanting to do Hep C at SAS for a number of years. So we had a great little chocolate peanut butter moment where we decided, hey, let's just do Hep C everywhere, and that's what we did. And we're here to talk to you about our program, how we launched it, and how it actually works. First, we have no disclosures. We haven't been bought yet. I don't know, so it's all good. So. We know Hep C is a big deal, and in our community in San Francisco, there are about 12,000 people who actually need Hep C treatment, and we are setting out a goal to actually get all of them. But most importantly, we know that gay, queer communities, and injector communities, and trans feminine communities are all disproportionately impacted by Hep C, and they're also disproportionately impacted by access to healthcare. So we wanted to solve that. So we developed a big Hep C program. So now at the foundation, at San Francisco AIDS Foundation, any of our testing sites, you can get tested for Hep C. We even added a program at our clinic at Magnet called Magnet Express. You can drop in at any time, get a full sexual health screen, including HIV, hepatitis, gonorrhea, and chlamydia without an appointment. So it's low barrier, in and out, everyone's getting tested. Now, everyone who tests positive, you then need to get them into care. So we started a Hep C treatment program where our initial goal was to help people who are out of care. Turns out it's more than that. But we actually can treat Hep C for people who are out of care. And we also have a very robust Hep C navigation team that Pauli leads that provides morning treatment support breakfast where you can come in, get some food that you need to take with your pills. There's storage lockers so you can keep your meds locked up because you get your stuff stolen every night when you're living on the streets. And just a lot of counseling and support for your treatment. Now, the Harm Reduction Center is a really cool place. It's down on 6th Street, which is like the place to go to score if you ever are on substances. And that is a very valuable fact because everyone's hanging out there, and it makes it very easy to reach people to get them into care. It's a small place, but it's really cool, and we get to do a lot of cool stuff in there. Now, for our program, you have to be over 18. This is the law. We can't do teenagers without consent unless they're emancipated. And because we're in that location, they have to be generally healthy. If you have a decompensated liver, you have a whole lot of clinical issues, this is not the place for you because it's like me in a tiny little closet room with a phlebotomy needle. That's the extent that you get. We prefer you to be mono-infected because if you're HIV positive, you're hopefully in care, but we will make exceptions to everything. But one of the highlights of what makes it easy for us to do is that we don't have to bill professional fees. We get to do everything for free, so it makes it easy for insurances and stuff like that. No one has to change their medical home. You can just walk on in, doesn't matter where you are, we'll get you taken care of. And we're also able to treat uninsured and undocumented clients, which is really cool. We actually did our first one, so I know it actually works. So you actually don't even need insurance, and it's just a very big privilege to be here in San Francisco where you can actually have such easy access because it's not the case in the rest of the world. Now, if you haven't met me, I'm a very impatient person. I like things done right away because clients want things done right away. And in the world of HIV, we have all these privileges where people test positive and then we send them out with pills. But when I came new to this world of Hep C, it was all about delays and reasons why we don't treat and why you should wait for all these labs to come back and everything. So we're bringing a lot of this test and treat model from HIV into Hep C, and we try and do this quickly. So Pauli will usually find clients through his outreach, or they'll test positive through one of our testing locations. They'll come in, they'll get screened, we draw labs, and my goal is to have them started within 1 to 2 weeks. A lot of it just depends on how fast I get the labs back and how much a pain in the ass the insurance is being. But most people I can do 1 to 2 weeks. So they come back in, after they get screened, we do a lot of counseling about Hep C, the treatment, how to prevent reinfection. We see them at week 4, we draw some more labs, we see them again at week 8, and then they come back for the SVR12. And during that whole time, they're getting supported by Pauli's team and the locker programs. So far, we started this in August, and this is me 1 hour a week on Mondays. We've done 6 people over at our Magnet location in the Castro, and we've done 26 people down at 6th Street. One of the things I do appreciate about this program is that diversity, even though we have not been intentional about anything, just being there, we're getting a fairly diverse population, which I appreciate. So we're reaching a lot of important people. Their mean age is around 26. We have as old as 69, and I'm sorry, mean age is 44. The youngest 26, as old as 69. One of the fascinating things is finding out if people are in care, and a good chunk of them are not in care, and that seems very obvious. But there's also 6 of them who actually had a primary care provider who could have done this. And when you ask them, why are we doing this and not your primary care provider, you end up getting all these responses of like, I don't have faith in my provider to be able to do this, or my provider judges me for being a substance user, or in order to get treated for Hep C, I'm going to have to divulge I have a relationship with substances to my provider, and I don't want them to know. So we take you as you are, and we'll talk to your provider if you want us to. If you refuse, we won't talk to your provider, but we're here to get you treated and taken care of. So we've started 33 people on treatment since August. 15 of them have completed treatment. We've only had 2 people over the program who actually didn't finish their treatment. Hopefully they'll come back. They like popped a pill and then disappeared. And we have 7 documented SVR12 so far, so we know that they're cured. But Pauli's team overall has gotten 42 people to SVR12 because he will take care of people in our treatment program, but also outside of our treatment program. The things that makes this easy for us to do, these newer 8-week treatments are amazing. 8 weeks is so much better than 12 weeks, let me tell you that. It's like, and so that makes our lives a lot easier. The fact that as a nurse practitioner, I can prescribe this, I don't need to see a specialist or anything, makes it much easier for us to do. Not every state allows that. A lot of states require you to see some hepatologist or something else like that. There is no need for that. NPs can do this, it's very easy. I'd mentioned before, we don't have to bill, so I don't worry about what network you're in or what type of like Medi-Cal insurance you have or anything else like that. Medi-Cal in California is fairly generous to actually access Hep C treatment. If you have a risk of foreign infection, they tend to fast track you. But you should only have to prove that you have Hep C, and that's it. That should be the only barrier you have. So while it's good here, it's worse in other states, but I'm listing it as a slight benefit here because it's easy for me to get coverage for people. The other thing that we've been doing that makes this easier, we've been adding in more wraparound services. We originally were just going to focus on Hep C. We started adding PrEP, which was really cool. We're starting to add wound care. We want to do a whole bunch of other stuff, including Bup and all these other little things that give people a reason to come in. They might come in for their abscess drainage, yet they're going to get treated for Hep C at the same time. The main barriers that we have, nurse practitioner autonomy does not exist yet in California. You are limited to 4 nurse practitioners per physician that you have. So we already have this clinic, we have a physician who we work with, and if you want to expand anything, you would have to hire another physician just to like work with that NP. So we need more nurse practitioner autonomy where you can just have a nurse in a closet with a phlebotomy needle anywhere at all these locations where people are hanging out and cure Hep C. So it'd make my life so much easier if I didn't have to worry about that. Blood specimen collection, things that we don't think about. I'm in that hot little sweaty room trying to get blood off of people who sometimes can't even stick themselves anymore. And so oftentimes there's vast amounts of blood that we want. So we had to like learn little tricks using microtainers, pediatric tubes and stuff like that in order to get it done. There are newer technologies coming out that just use a capillary stick, but drawing someone's blood is a pain in the butt and it's very hard to do because they want so much blood. And then funding. So right now I'm there 1 day a week for 1 hour. So we're hoping to find more funding so we can keep expanding and doing more of this work every day. So I don't know if you want to do a little, I'm doing a little shout out for our whole little team. I don't know if there's any words you want to say before we talk as a group or whatever you'd like.
I have just a couple. Hi, we're running a little late, so I'm going to talk really fast. No. So I've been doing Hep C and Narcan. September will be 20 years in harm reduction for me, and I started with HIV. And I noticed when I first started, you know, that the underlying unspoken stigma, and the way I view it is like people that were considered disposable. And I'm old enough, I was around when all my friends were dying so quickly in that first years of HIV and how virulent that disease was. And I think that it's unspoken that some people are like drug users, gay folks, some people are considered disposable. It's unspoken, but I think that it's underlying. I think the stigma is institutionalized, and it's a big thing that we fight. When I first started doing Hep C work in 2002, it was all about just getting folks into clinical trials. And I don't usually out myself, you know, with this stuff, but I had Hep C for 32 years, and it almost killed me, and I ended up with F4. And my doctor, and I had 20 years on that side of it, and 20 years on this side of it. And so I'm able to use that experience. It helps a lot because folks trust me, and I know everybody, which helps. But the thing, so it also gives me a way of looking at things where like, why can't we do this and this and this? I enrolled 4 people yesterday. I had enrolled 3 people yesterday, and I was telling Katie Burke, our viral hepatitis C coordinator, and I do want to say something about End Hep C. We have an End Hep C program in San Francisco that Katie heads up, and to me, it's not a program, it's a movement. Paul Harkin is here from Glide and runs amazing, huge hepatitis C services. This is more than just a health paradigm, it's a movement. Just like harm reduction is a movement. This is a movement to end Hep C, and we are a part of that. And our task within that is to deal with active drug users, chaotic drug users. And so we get to do it at the Harm Reduction Center, where we have tremendous wraparound services. We have needle exchange and Narcan availability 54 hours a week, plus 7 mobile sites. And we have a Hep C group on Monday. And at this group, I wanted to do Hep C care at the group. I wanted to do Hep C care at the needle exchange. And some people here are kind of nodding because they heard me broken record it. And sometimes that's the only way you get things done. And so the way that I used to have to do this was that it was mandated that folks were not to get treated for Hep C until they earned the right to be cured of the deadliest communicable disease by being clean and sober for 3 to 6 months, which is, you know, how do I put this clinically? It's bullshit and not working. So for a long time, it was about getting folks to treat active drug users. And I had wonderful doctors who were open-minded and progressive who knew that if I brought in a client, that they were an active drug user. And then, you know, and so the person, this doctor that I'm talking about, who's still one of my heroes, along with Barry Zevin, would sit there and she'd go, are you and she'd go, active drug user with the box. And she'd look them up and down and go, oh, apparently not. And she'd like, no. And I would say, just don't do a hit in front of her and it's gonna be okay, you know? And it was. And then, so the things have changed where we can treat active drug users. So my next question and my next push within these groups is, why do we have to make people jump through hoops for Hep C care? I went through it and it almost killed me. And I can tell you that the brain fog that is not talked about, that the fatigue that is talked about, and the depression that is talked about, it's not just debilitating, it's disabling. So why not get people healthy first and then see if they can make the appointments that they'd never make? And they do. So what we do for care now is we enroll them for Hep C care right away. We don't make them jump through any bloody hoops. We sign them up because people feel better after a month. It's one of the great gifts of this is you get to see people better after a month. And all of a sudden, they can make appointments that they've never made before, as opposed to waving a magic wand and suddenly they're going to make these appointments. I talk to every single Hep C client that we have, and I always set a secondary goal, which is anything from I wanted them to leave our care with a primary care provider, but it doesn't necessarily have to be first, is what I'm saying. But we make a secondary goal, like getting housing, getting a job, going back to school. It goes on and on and on. Calling people's families. I've called 3 people's families who hadn't spoke to their family in more than 10 years, and they had something positive to report. I'm cured of Hep C, I feel so much better, and I got housing. I call and talk to their mom, and then I tell her this and then hand the phone over. It's a tremendous gift. But I think that this is, and doing it at needle exchange, if there's one place where folks go, they go to the needle exchange. By going to needle exchange, they are showing us that they do care and that they want to do this. So I say we do care at the needle exchanges, just like we're doing. And I think it's important to have wraparound services at needle exchange. Our Monday group is where Pierre does the care. We provide really good food. I actually lobbied for it because I tell people all the time about, we want you to eat healthy and then we feed you only pizza. So we don't do that. We actually provide really good food. We have Hep C care there. We're going to have wound care there. We have 4 clients on PrEP. We just got our 4th client on PrEP. Her partner's HIV positive. A lot of clients are sex workers. The 3 people I enrolled yesterday, 2 had primary care. One said it was this short guy. I think he might have been Asian. The other person had no idea, and the other person, their primary care was the ER. That was the primary care reported. We got to do this the right way. We've got to go in and get folks feeling better and then treat them. And I can tell you that from personal experience. And I want to go quickly. There's one more thing I want to say, which is I've been doing needle exchange for 20 years, and I started a little site at 16th and Mission, which is now a big site. And we have a thing there called the Narcan tree, where we bury Narcan under a tree. And I know the folks in the community, and I just re-up the Narcan every week, so there's always been access to Narcan there. Now we're reaching out to folks, and I think the most important next step is we've got to go to people. Like, to me, harm reduction, meeting people where they're at, is largely physically going and meeting them where they're at. Hep C almost took me out. Opioids almost took me out. And I got to say something, that being here, it's really, I'm not usually scared to talk to people. My dog wore a bow tie, so I look good. He's the best outreach worker ever, let me tell you. But I'm sitting in a room with people that I look up to and idolize, and with Barry Zevin, who doesn't know it, but saved my life. I wouldn't be standing here without Barry. So thanks very much, and I'm honored to be here with you all.